Hello everyone, hope you all are doing well. I'm Dr. Ishani Fernando. I'm a general practitioner from Sri Lanka. Today I'm going to discuss with you how you should approach a NAC OSCE station if the patient presents with tremors. So tremors can come as a history-only station or history and physical combined station. As you may know, in NAC OSCE, you will have 2 minutes at the door, and to take history and to do physical examination, you will have another 8 minutes, and you will have 3 minutes for the post encounter. So if it's a history only station, you can take the history for whole 8 minutes. But if it's a combined station, you will have to manage your time to take the history in 4 to 5 minutes, and you'll have to do the examination in about 3 to 4 minutes. In this station, patient will present to you with shakiness in his hands or trembling in his hands. So as I told you, you will have 2 minutes at the door. So these 2 minutes you can use to jot down some differentials such as Parkinson's disease, cerebral disease, hypothyroidism, anxiety, essential tremors, drugs, and hepatic or uremic encephalopathy. So during your encounter with the patient, you can ask at least few questions to rule out these differentials. That way the examiner will know that he will know about your thought process. Okay, let's talk about history taking first. When you enter into the NAC OSCE station, first you will introduce yourself and get the consent to take the history and clarify the presenting complaint with an open-ended question. Like if you have the presenting complaint at the door, you just ask, I understand that you're here because you have shakiness in your hands. Could you tell me a bit more about it? Or if you don't have the presenting complaint at the door, just ask, what is it that made you come here today? And then, depending on the patient, what the patient says, you try to gather information about onset, cause, and duration of the complaint. So you can ask, when did this start? How did this start? And is it there continuously, or have you noticed that only on some times? And you can ask, is it getting worse with time, or is it just the same? Then ask all questions about tremor, specifically where he noticed tremors in his body. If the patient says that he has tremors in his hands, ask in which hand. Is it in both hands or only on one hand? And also you can ask where else in his body, whether he has noticed any tremors in his head or anywhere else in his body. And then you can ask, is there anything that makes this tremor worse? And make sure to give some examples, like have you noticed it's getting worse with activity, or when you are anxious, when you are tired? And also ask, is there anything that makes this shakiness relieved? That way you can differentiate between resting tremor and intentional tremor. And also it's good if you can ask how this has affected his day-to-day life. And at this point, if the patient expresses some difficulty in maintaining his daily activities, it's a good point to show your empathy. You can say something like, oh, I'm sorry to hear that. I see you're quite concerned. This is quite concerning to you. How are you coping with this? And that will give you some more marks. Then you go on to ask about other neurological symptoms. Here I have mentioned gait first, because most of the time this station will come as Parkinson's disease or cerebral disease, so the gait will be affected. So you ask the patient whether he has any difficulty in starting to walk, Any problem with his balance? If so, when did that start? And most of these patients will be elderly patients, so ask about history of falls. Did you have any falls in the past? If he had any falls, you have to inquire more about the fall. Ask him, when did this happen? How did this happen? What were you doing at that time? And did you injure yourself? Did you lose your consciousness? Did anyone see you falling? And basically to get to know why he fell down. Is it because he had some dizziness, or is it cardiac related, or is it just he fell down because of his imbalance? And then ask him whether he's able to move around alone or whether he needs any support like a walker. Because this is a neurological case, you first finish asking about all the neurological symptoms. For that, you can use the mnemonic called DDD-AVP plus incontinence. So you ask about headache, double vision, difficulty in speech or slurred speech, difficulty in swallowing, numbness or weakness anywhere in his body, and urinary or fecal incontinence. And because these patients are elderly patients most of the time, ask about the vision and hearing as well. Then we are going to ask about questions to exclude differentials. First, let's talk about Parkinsonism. Parkinsonism is a clinical diagnosis. Patient should have bradykinesia along with tremors or rigidity or postural instability. So you asked about tremors first, and then bradykinesia and rigidity you can see in the physical examination, and the postural instability you asked about imbalance before, and also you can check the orthostatic vitals in physical examination. Then ask about the specific features in Parkinsonism, like any changes in your writing, like micrographia, drooling of saliva. And these patients are most of the time elderly patients, so ask about activities of daily living and the instrumental activities of daily living. You don't have to spend a lot of time on this. You can just ask a few questions like, are you able to feed yourself? Are you able to wash yourself on your own? Who is doing shopping for you? And are you able to manage your financial accounts on your own? Okay, and then you can ask about strokes in the past to exclude vascular Parkinsonism, and any changes in the memory, because dementia is a late finding. And you can ask about the mood, because most of the time these patients will have low mood. You can screen with MI, that is mood and interest. Just ask, how are you feeling these days? How is your mood like? Are you able to enjoy things that you used to enjoy before? If MI is positive, you can go on asking about all the features of depression. Otherwise, you can just skip that and go to the other questions. At this point, if you feel it's Parkinsonism, you can ask about the constitutional symptoms as well. But if you don't feel it like it's Parkinsonism, go to the other questions to check what the diagnosis is, to rule out the other differentials. Then we'll ask questions to exclude other differentials. Next main differential would be cerebellar disease, but I didn't mention that here because we asked all the questions, all the neurological symptoms before. So the cerebellar patients will have intentional tremor. So we asked everything, all the questions about tremor, and they will have imbalance, gait problems. So we asked all the questions about gait before. So the next differentials would be hyperthyroidism. You can ask whether the patient has heat intolerance, whether he has any problem with his bowel habits, Have you noticed any changes in your weight? And then you can ask about questions on anxiety, like, are you a person who worries a lot? Do you have any specific fears? And then hepatic or uremic encephalopathy. So this you will cover in past medical history. Drugs you will cover in medications, and essential tremor you can ask about the family history. Now we are going to ask about the past medical history. So before without just asking the questions, it's better if you can give a statement of transition, such as, now I'm going to ask you a few questions about your past medical problems. Have you had any liver problems, any kidney problems, something like that. And then you ask about previous hospitalizations. And then the medications. There are certain medications that can lead to Parkinsonism, drug-induced Parkinsonism, like typical antipsychotics. And there are other drugs which can cause tremors, like beta agonists, theophylline, lithium. Okay, and then you can ask about family history. You can ask, do you have any family members who have had similar symptoms? Then comes the social history. Always have a transition before asking about the social history. And in the social history, you're going to ask about questions to rule out elder abuse as well. So you can ask something like, now I'm going to ask you a few questions regarding your social background, and some of these questions may be very personal to you, but I assure you whatever you share here will be kept confidential unless it is requested by law. After that transition, you go on to ask about social history. You can ask smoking, alcohol, recreational drugs, and caffeine. How much cups of coffee do you drink per day? And about the home environment. With whom are you living at home? Do you feel safe at home? Is there any chance that you've been mistreated or misbehaved by anyone? And then ask about how do you support yourself financially. Then comes the most important part, ideas, concerns, and expectations. This you can ask either in the history of presenting complaint or at the end. You can ask, what are your concerns? What are your expectations from us today? What do you think must have caused this problem? And how has this affected your life? This shows the empathy. So it's very important you ask these questions somewhere in your history taking. After history taking, then comes physical examination. So first you thank the patient, explain what you're going to do, and obtain consent. So you can say something like, let's say if the patient is Mr. Smith, you can say, thank you, Mr. Smith, for providing me with all this information. Now I'm going to examine you. In this examination, I will inspect you. I will ask you to do some movements, and I will ask you to walk. Would that be okay? Then ask the vitals. May I have the patient's vitals, please? At this point, if you identify any changes in the vitals, you can comment on that. And also, if you want to check orthostatic vitals, you can check at this point, or else you can check it at the end. So I have mentioned here the steps that you need to cover in the physical examination, but the order you can change. This is the order that I preferred. I started with upper limb examination. So first we are going to check for the tremors. So ask the patient to keep the hands resting on lap, like shown in figure A. If patient has tremors at that point, it's resting tremor. And ask the patient to keep the hands outstretched, like in figure B. If the patient has tremors at this point, it is postural tremor, and it is seen in hyperthyroidism, and essential tremor. In Parkinsonism, the patient will have restrained tremor, like in figure A, and patient will not have tremor when he has outstretched hands, and it will appear again. So the tremor that is present when resting and disappears with outstretching and reappearing again is very likely to be Parkinsonism. And also you can do a check for bradykinesia by finger tapping tests, like shown in figure C and D. You can ask the patient to do it as big as they can and as fast as they can. Then you can do the finger nose test, which is very specific for cerebellar disease. You can find intentional tremor and pass pointing with this test. Then you can ask the patient to check for dysdiadochokinesia, the rapid alternating movements, and also check for flapping tremors to rule out hepatic encephalopathy. After examining for tremors, you can do the full neurological examination of upper limbs. So inspect for muscle atrophy and abnormal movements. Check the tone, especially followed by rigidity and cogwheel rigidity. Check for the power, reflexes, and do the sensory examination for light touch in all dermatomes. Then do the general inspection. You will look at the face for masked face and check for a goiter if you are thinking about hyperthyroidism. So if you think hyperthyroidism in history, then the examination would be different. And there you will have to assess the goiter. You will inspect the goiter, palpate for the goiter, and check for eye signs. So I'm not going to talk about that in this presentation. This is more focused on Parkinsonism and cerebellar disease. Parkinsonism patients will have a monotonous speech. Of course, we took the history and we can comment about the speech by that. And then you can ask the patient to stand up to check for the posture, stooped posture, and you will assess for bradykinesia as the patient stand up. And ask the patient to walk a few steps, turn and come back. That way you are checking for shuffling gait and arm swing. If the patient has a cerebellar disease, the patient will have a broad-based gait. Next would be orthostatic vitals. If you have time, you can check for orthostatic vitals. If not, you can just mention that you are going. I would like to complete my examination by checking for orthostatic vitals and doing full neurological examination of lower limbs and cranial nerve examination. But if you have time, you can check for the orthostatic vitals. You can just mention that I'm gonna ask the patient to lie down for 5 minutes. And I will check the blood pressure and heart rate and ask the patient to stand up. And again, I will check the blood pressure and heart rate. If there is a drop in at least 20 in systolic blood pressure, or at least 10 in diastolic blood pressure, or a rise in heart rate of 30 beats per minute, would indicate of orthostatic hypotension. And then you wind up by saying, I would like to complete my examination by doing full neurological examination of lower limbs and cranial nerve examination. After your history and physical examination, it's a post-encounter. You will have 3 minutes for your post-encounter, and there are a few questions that you might that they might ask you. So they can ask you to tell your differential diagnosis, or if it's a straightforward case, like for example, Parkinsonism, you might be asked to give your working diagnosis. Then also you can be asked to give a summary about the patient. So in this question, you just summarize the history and the physical examination, the positive findings that you found. And if you ask about the investigations, Parkinsonism is a clinical diagnosis with bradykinesia. Your patient will have bradykinesia with either tremor, rigidity, or postural instability. And we do head CT to exclude stroke. If you're asked about management, the most important thing is neurology referral, and the neurologist will decide what the treatment the patient needs. The mainstay of treatment is levodopa and carbidopa. Apart from the neurology referral, depending on the patient's history, you can mention other management steps, such as referring to a social worker. So these patients will be elderly patients most of the time, and they will have imbalances, gait problems. So the social worker will help to adapt the home environment to suit their needs. So these are few questions that might appear in your post encounter. So I hope this presentation helped you to get a good idea on how to evaluate a patient presenting with tremors. And I wish you all good luck for NAC OSCE and for your licensing journey in Canada. Thank you.